They
Morning, everyone. Calling you to attention, Sandra.
Sorry, that's my fault.
You wouldn't all like to sit in the front row, would you? Given there aren't very many of you. Come on, Mr. and Mrs. Ash, join everybody else. We're a bit depleted because nearly all our Neds seem to have the flu.
They're in the best place.
They're not in They did have their flu. And we're having no filming because we're doing it ourselves, please.
No, we will film it, Daniel. We have a much larger audience than you do, and we'll get it out soon.
So if you're going to film it, I'm going to ask you to leave.
You
Because
can't, it's a public meeting. I'm entitled by law to film this.
so in this case, respect our rules, which are that
Your rules are illegal. I am entitled to film this meeting.
So we're entitled to ask you not to film the meeting, particularly if we are.
You can ask and I can refuse, and you don't have the right to throw me out of a public meeting. I have not broken the law. I have not insulted anybody.
It's around some feedback we've had from members of an audience where filming is taking place. They don't want their...
We haven't filmed the audience, we filmed you. You are public employees. We are entitled to make you accountable to the public, and that's why I intend to film this meeting.
But that's why we have filmed it, and we're very happy to make that film available.
So we're not going to do the meeting if you're going to film it.
There's no point in having it anyway, because there's no member of the public here.
Sorry, what am I?
Sorry, I didn't see
I
you.
am a member of the public, and so is this gentleman.
Okay, so there's 5 members of the
And I
public.
would like to hear what they're going to say, if you don't mind.
Okay, well, will you film this refusal, please? I think we need the public to know about this.
And that's exactly why we are filming it, and we will make that film available on our website, and you're very welcome to either put a link to that or
And will
put
it
that on your
include your
website.
refusal to allow me to do what I'm legally entitled to do?
So on our property, it is our call as to whether we let
It's
you.
not your property, it's my property, I pay for it.
Sorry, you're not allowed to video at the town hall.
You are.
You are?
Oh, I'm sorry.
better
Not
check the
in
laws.
public meetings.
You certainly are.
It's precisely
Not
because
in
it's a
mine.
public meeting.
So,
We get security to remove you.
and we don't want to do that, so please respect our
Yes, you
wishes of
don't.
not filming.
That'd be great publicity.
So are you going to then participate in the
Yeah, we'll
meeting?
say, Daniel, that we believe we have the right to film.
You know it.
Lawrence sends his apologies. He's hoping to make it in further late in the morning. So let's do the performance report. Home medical directors, which of you are starting with say?
I'll start as usual, and as always we'll really pick up key points. So starting with 1.1, which is looking at mortality, our trust HSMR remains below the national average. You'll see further information on the split between the HSMR for elective and non-elective admissions, for which there is no significant difference. And similarly around weekend mortality too. Important to note, looking at the last bullet point, that we of course took a detailed paper to the December board looking at how we are reviewing the care of the patients who die whilst under Epsom St Helier in line with the learning deaths framework, and that paper is uploaded onto the website from the December board and gives a much more detailed breakdown of how we're reviewing mortality. In terms of domain 1 and 2, you will see that in terms of stroke care, we still are struggling with having enough capacity on the Epsom site, particularly for our patients to spend the majority of their care on the stroke unit, and a lot of active work underway to ensure that we have the right capacity trust-wide. As I said previously, given the ongoing thrombolysis which is taking place based on this site at the moment. In terms of transient ischemic attacks, we've still got some data outstanding for October, but actually the low indicator here is a reflection of difficulties in communication between GPs and the acute trust, because general practitioners are not always cited on the imperative to refer these patients urgently. We're doing some significant work in primary care to mitigate that. And I think in terms of dementia and VTE, what I would say is that the data here is still October data. You'll know that we started rolling out our electronic whiteboards on wards just after then, and we're actually starting to see, I think, an impact in how those boards are driving up compliance with those key metrics. And in terms of dementia screening, I'm not going to make much of a 2% increase, but actually from October we started to see the impact of our new care of the elderly senior physicians being on site, and I think that will make a further impact as the months progress. To pick up key issues on 1.3, what I do want to highlight is the concerns here around the comprehensive incident submissions in month. And what this reflects is that during the month of November, there were 5 comprehensive investigations due to be submitted, 3 within medicine and 2 within women and children's. And because of complexities in the cases and operational pressures, most unusually for us as a trust, none of those 5 cases were submitted within the allocated time frame. So that's something we've picked up individually with the divisions. We've reversed that position, we're now back on track, but it's a reflection of the pressures that the teams were under in month. And I'll hand over to Charlotte.
Just before Charlotte, so on stroke, just to add that Surrey Downs CCG has confirmed that Epsom Hospital will continue to be a hyper-acute stroke unit in the year 18-19, and have provided us with additional funds to recruit some more staff so that we can deliver the standards.
So I'll report on staffing 1.4, and this is for November. It's relatively stable, however, I think it's fair to say it's been very challenged going into the beginning of December and beyond. And we've managed to keep the levels of staffing up because our clinical nurse specialists have been on the board, our matrons have been providing care, and we've drafted in some of our non-board based non-clinicians, so the staff in the back office to come and help support us at meal times, for instance, and that's really been helpful. Staff continue to work under pressure. We're still recruiting internally or locally with good numbers, and we've started our associate practitioner programme in December, so that's good. From an infection control perspective, we had 1 MRSA bacteremia reported for November, but we now know that that's community acquired, so it will be removed. We've been lucky not to have large amounts of norovirus that are out in the community, but we are now beginning to see flu on our intensive care and on our emergency wards. Moving on to maternity, the cesarean rate is slightly higher because we're now seeing an increase because patients and ladies with reduced fetal movements are brought in to be either induced or have cesareans, and that's a change in the national guidance. I'm pleased to see the severe postpartum hemorrhage has remained stable since August, so fingers crossed, and I know for December that's continued, so the changes that they have made in the service hopefully will be sustained. And then I'll move on to Lisa.
On patient experience, I draw the attention to the friends and family test, particularly around maternity. We are continuing to increase the steady month on month the number of responses of people responding to the survey, and what's really positive to note is we are seeing an increase in the number of responses. We're also seeing an increase in the recommender score, so that's the number of people who are actually saying they would recommend the organisation, the service for a for care and treatment. So that's a real positive. And we're also continuing to maintain positive movement in terms of the response rates above the board, either sustaining them or improving on those. So that's through reintroducing paper-based systems, which some of our patients really like, as opposed to just using an electronic system. The performance on PALS is really strong. We are seeing a huge number of month-on-month increase in people using the PALS service, and that's largely due to the time of year. November, December and January are our busiest times of year, but also to the fact that we now have a better coverage across both of our sites, with our teams working across sites. So this enables patients and members of the public to access that service a lot easier. So we would expect that rise due to two things. In terms of complaints, we are continuing to see improvements month on month around responding to complaints. That is likely to take a dip in December and January, purely one due to the volume and also due to the fact that our clinical teams are really, really busy. But we are working very strongly with those clinical teams and also those people who have raised concerns about delivering to a time frame that suits their requirements.
Thank you. Dan, cancer?
So, we start with cancer. Cancer is nationally reported a month in arrears with the rest of the performance released data for October, in which shows we met the 2-week referral rule with 96.1, which is really encouraging. Decision to treat, first treatment was very strong performance, which is the number of patients we need to treat within 31 days of that decision, and there was only one patient who didn't manage to achieve that for out of 78. Subsequent treatment, which is people who require follow-on, again, very strong performance. The area where we've taken a slight dip, and although we're meeting the standard across the year to date, in October we only achieved 80% against a standard of 85% for those patients waiting 62 days for cancer treatment. The two key areas in there were lung and urology, both of which were having individual capacity issues. And our data for November's performance would indicate that many of those have now gone away. We've returned to 85.1% performance for November. So I'm satisfied that this appears to be a temporary issue rather than something more ongoing. I'll move on to elective care pathways. We're still not achieving the 92% standard, but November did see an improvement in performance on both September and October, with a very small change in the number of the total backlog, which remains around 2,900. We're putting in place an action plan with both our commissioners and the NHSI, and at the moment we're working through how long it's likely to take us to recover that position, given the scale of our current non-elective challenges and the number of patients we're going to need to work through. In terms of diagnostics, we managed to achieve the standard with plenty of room to spare, which is really encouraging. And our elective length of stay has dropped both overall and for patients over 65 years old. And in both of those, I think that's enough of a change to indicate it's a substantive rather than a statistical variation. So that's really promising. And although we didn't achieve the number of elective operation rebook standard, in that we did not achieve 1% standard, we dropped from 4 cases, we didn't manage to do so, to 2 in November. And that is a very strong long-term improvement, which is really encouraging.
Which we should also say in November, we did more elective operating than we've ever done in any other month in the normal working day, Monday to Friday, because we've been relentlessly focusing on improving theatre efficiency.
If we move on to emergency care pathways, in November we did not achieve the 95% standard for emergency care access to the hospital, achieving 93.1%. And then when you add in all other activity, an overall performance of 93.8. The reasons for this appear to be many multifaceted. There seems to be a change in the time at which patients are presenting, particularly with serious conditions, moving to later at night, and we're looking at our staff volume mix to compare with that. And also when you compare November last year to November this year, there's absolutely no doubt there's been a significant shift in acuity. So although the overall volume of patients being treated is broadly static, the numbers coming through our majors and resus phase compared to the numbers coming through minors has changed, and the balance has tipped quite significantly, meaning that we have to give more time to each patient, often out of hours. In terms of non-elective length of stay, that increased by 0.1% to 4.4 days. And I think that's probably statistical variation. We'll just need to keep an eye on that in terms of what's normal. But we're still well below the levels we delivered in the previous 2 years, which I think is encouraging. Delayed transfers of care, so those people who are medically fit but are awaiting some form of package of support from social services, has again dropped to 0.9% of our inpatient bed days. And again, that's a reduction against our year-to-date position. Ambulance arrivals is an interesting issue in that our numbers have increased, but also it's proving more challenging to offload them all in as timely fashion as we would want to. And again, I think that's down partly to the layout of our departments, but also the acuity of the patients who are already arriving. And therefore we're seeing some delays there. We've got action plans ongoing with both London Ambulance and South East Coast Ambulance Service to work out both whether we can manage the flow of ambulances around the system and also to look at whether there's anything we can do in the very short term to improve that position. And that, I think that covers London Ambulance handover weights. It's probably worth stating that our year-to-date position for emergency care pathways remains over 94%, and we remain third in London and in the top 20% of the country. So it's not where we want to be as a trust. I think when you look at where we are compared to the rest of the country, we remain strong performance.
Yeah, so the BBC yesterday on their tracker published the December A&E data, so they're getting it more quickly than we are now. And there are only 3 trusts in the country that achieved over 95% for December, of which we're not one. There are 18 trusts out of the 150 in the country who achieved more than 90% for December, and we're one of the 18. So we're still we're still doing relatively well, even if absolutely it is not as good as we would want it to be. Who would like to do workforce section? Does anyone have a view? There's not much to say on workforce that we haven't said in previous months. The really good news story in nursing is we're now in our 4th month in a row where the number of joiners of nurses has exceeded the number of leavers of nurses. And you can see in our total clinical workforce, the last 2 months are the highest we have ever achieved.
And Whitbread is fully established now, so all our midwives are in, and the emergency department at St Helier is now fully established.
I think it's fair to say that for medical staffing there are ongoing challenges. There are a number of vacancies in some of our key specialties. There's a huge amount of work between the clinical, managerial and the HR teams to ensure that the rosters are filled.
Okay. Comms?
In November, just shy of 47,000 people visited our website, unique visitors to our website, with the highest search being on jobs. So our website continues to be a very important piece of the jigsaw in terms of helping staff to look for recruitment with us. So that's really positive, and we continue to work on that. And then in terms of the media, we had a lot of interest during the period around Epsom and St Helier 2020 to 2030 campaign, which we responded to.
Okay. Money. So as at the end of November, we were on track to deliver the planned deficit we have been set. I can confirm at the end of December we are still on track. So that is very good to know. And if you walk around either of our sites, you can see just how much money we're spending on capital. I went in this morning to the new extension to A&E on this site, which begins to open next week with Charlotte.
Great.
There'll still be a building site when it opens, but when the time it's finished in about a month's time, A&E will be a third bigger inside here than it was. So people like Mike, if you hadn't retired, you'd have an even better space to work in. How to tempt you back. It does the odd shift here, but I think do more. There we go. Risk.
So, this month's risk register has 3 material changes to it. There's 2 new risks. One reflecting the pressure the emergency department is under, and you've already heard the brief analysis of the impact that's having on the result of our ambulance handover times. So that's one new serious risk. The other relates to the pathway of care for our patients who have heart conditions, for those who are renal patients, and managing the flow whilst they're waiting for a cardiac intervention that George's provides is suboptimal and potentially presents a risk to patients, and therefore that's one of concern. We have some regulations in place, but they need to be further strengthened, which is why we have this in our risk register. The third component that's changed is a rescoring of an existing risk, which relates to the capacity of the organisation to manage all the changes and pressures that we're under, whether that's operational, financial, or workforce, all the things that you've heard about, and not just with the CQC here this week, but our view is this now needs to be scored from a 20 to a 25 because it is having an impact on our ability to deliver all of the things that are expected of us, including the constitutional standards. So that's a new one. There's further what we need to be doing to see whether we can delay, defer, or de-scope some activity or programs of work to enable us to bring that down within a more tolerable bounds. So those are the 3 major changes to the system.
Okay. Strategic update, all things. So firstly, as Peter just said, we had a full hospital inspection from the CQC this week. There's been between 40 and 50 inspectors. They've been here for 3 days. They gave us some high-level feedback last night after they left. Would you like to go on board?
I think the important message really to convey is that firstly the inspection team are very complimentary about being posted in at a time when the sites were under such immense pressure. They really recognise that. But actually what they observed at such a time of high activity was very strong care being delivered to patients. They saw lots of examples of significant improvement since the last inspection. They saw lots of examples of caring care, and that was something in the last inspection that very regrettably did not come across strongly when the team were here. So they saw lots of very high calibre caring care. They really recognised the improvements that had been made specifically in maternity care across both sites, within critical care. They saw innovation in children's services, in medicine, and did not issue us with any immediate actions that we needed to take because they saw no major issues on either side, which is very good news. As always, there is always stuff we could do better, and through the week as a team we've been very responsive to any early indication from the CQC of issues of concern, and they recognised that responsiveness. So there is no doubt we have more to do around ensuring our staff are fully embraced of mental capacity and DOLS training. Our staff are able to elbows consistently in all areas. That there will be no doubt many more recommendations that come through in the report. But I think the key message which we'll be briefing our staff on immediately before the board is that they saw at a time of huge pressure examples of really positive care. They really saw the significant changes that have been made over the last 2 years, and whilst clearly recognising the pressures and the escalation capacity we're using, I think generally very positive feedback. If I've missed, that was from memory, so
yeah, it was very good. And if all goes well with their timescale, we'll have a report in April.
It's perhaps important to actually highlight the change of process, isn't it, from the led inspection.
And there's a separate new rating on is the trust well led. So conventionally, in the old way of doing it, each service gets a rating as to whether it's well led, as well as whether it's safe, effective, responsive. Now there's a one for is the trust well led, and they're coming in for 2 days in February to interview all of us. And whether as leaders we are leading the trust well. That was the first one, CQC. Then I think we should just explicitly comment on the winter pressures. So this has been the hardest, most challenging winter anyone who has worked in Epsom can remember. The sheer number of very, very sick patients has tested us to our limits, and it continues to. I have to say this massive thank you to our staff. So many people have worked so hard and so many extra hours to try and keep our patients safe. So we've launched a thing called Winter Heroes. So if you know anyone who has treated you or your family who's gone over and above and done something exceptional, please can you let us know. We've been asking everyone for their nominations. I think we've had about 30 nominations so far. We want to have an award ceremony to say thank you to all those people in February or March. Every time we think that the winter pressures might be slightly easing, 24 hours later we realise they're not. It's really hard going, and it is taking up a huge amount of organisational effort and energy, and that's why we've had to change the scoring on the risk register about bandwidth, because we are all focused on dealing with emergency pressures to make it as good as it can be. The estates work I just wanted to pick up on. So there is so much going on both sides. The CQC did at one point say St Helier feels like a building site, and isn't that a fantastic thing for someone to observe just how much money we are spending on the buildings. So those of you who are astute will note that the big building work at St Helier is being one of the contractors is Carillion. The Carillion are clearly in the news. We have a plan B if Carillion go into liquidation or whatever the thing happens to them, to enable us to carry on doing the work with all the other contractors. So it will not stop, which is really very important to know. And then lastly, on our strategic outline case, so two things are now happening. So we have submitted it to NHS Improvement for them to begin to assure it. They sent us back 69 questions on it last week, which we have to respond to, but they have scripted a timetable where it goes to their National Finance and Resources Committee in March to begin the process of, is the NHS going to give in principle support for getting the capital to build the new specialist acute facility. So it's really very positive that we're now in their pipeline for the NHS making a decision on capital. And then, as you know, we had to hand over, this is what Epsom St Helier thinks the answer is, to our commissioners. And so now Merton, Sutton and Surrey Downs CCGs are in the process of setting up the governance that they need to do their assurance that the clinical model that we have proposed is right. And that is all in train. So I think we are at this stage still on track for getting to an answer on, does the wider NHS agree with our service model, and does the wider NHS want to support providing the capital, and the analysis on which of those three scenarios we put in the SOC engagement is the right one or ones to consult on, and doing a consultation on that in the summer autumn of 2018, of this year in fact. So that's where we've got to on that.
Can I think anything else strategic?
Is it worth talking about the effect of winter pressures on elective work?
Go on then.
It's clear that the hospitals nationally are under a lot of pressure managing the emergency work. Within this trust, we asked our consultants who are ward-based to spend much more time on the ward, supervising the junior staff and reviewing patients who are not on their normal wards, and we've mapped out the impact on outpatient clinics, and actually the impact on outpatients is relatively minor, so we hope that deferral of outpatients or postponement of outpatient appointments will be kept to an absolute minimum. In terms of operations, we are looking at the urgency of all planned operations. We are absolutely prioritising cancer operations and urgent operations. Most of our day case activity is still going ahead because that has very limited impact on the beds for the emergency flow. But unfortunately, some of the planned less urgent operations have had to be postponed. Dan, I don't think you have the numbers of where we're up to.
We've cancelled 37 operations this week. And since the beginning of December, we cancelled 139 operations, and that's planned to cancel in advance, as well as those we have had to cancel on the day. And thankfully, we believe those numbers are still quite small because we're looking ahead and predicting what our bed base should be. So we've been able to manage that reasonably well. The challenge, as James has said, remains around our bed capacity, particularly at the moment in this month, around our ability to flow patients out of surgery and into critical care beds. It's worth mentioning around a third of our critical care beds on the St Helier site and about 20% on this site are taken up with patients with flu, to give you some idea about the capacity issues that we're facing. And we don't know whether that is going to increase or decrease over the next few days, but we know there is flu in the system.
Okay. Anything else? Over to you. Any questions?
Yeah. I've got a couple from county councils that can't be here. Which services have been moved in the last 2 years? And I've got to write this down so don't speak too quickly.
Which?
Services have been moved
Across
from-
sites?
Yes, yeah. Like you brought...
So let's give this a go. So ophthalmology moved from Sutton to both here and St Helier, and that's a big investment and a big expansion of service.
So the significant change has been moving more of our elective work in the last year from St Helier to Epsom. So that's probably the most recent, most significant change.
We have brought onto this site the Epsom Health and Care team. So there's a whole bunch of community-based staff who were working in community locations who are now based on the Epsom site.
And I think we've probably co-located the critical care facility, or we've created a centralised critical care facility at the St Helier site for people who have ongoing needs. So there's regular review of patients at this site who have ongoing critical care needs.
So the answer is not a lot, actually.
Have you got any more in the pipeline?
Well, we've got a plan on this site to convert, so that building there.
That's Langley.
Langley,
Yeah,
which the Mental Health Trust was in,
yeah.
to bring more of it back into life or patient care. Because,
Sorry, what type of patient?
well, so we're just trying to work through all the permutations of how to do it, but hopefully there'll be more inpatient beds in that building that we can use. And that, so in the next phase of the plan, we have to do that, we have to connect it to this building. Well, currently to get to it, you have to go outside. So one of the things is we have to build a bridge. So Bess has told me since I joined that we have to have a bridge, and she's right. So it's in planning. So the reason why it's not a lot, in answer to your question, is because if you remember, we committed in 2015 to keep all our acute services on both sites. So what's actually going on is investment in all the acute services on both sites, so it's making them as sustainable as possible. And when we produced the SOC a couple of months ago, and we were asked, well, you think we can't have a new specialist acute facility until the mid-2020s, what are you going to do between 2020 and the mid-2020s? And the answer was, we want to keep everything as it is. We have to make still lots of investment to keep everything as it is. There's a big new, we've just tendered for building a new additional surgical capacity at St Helier, because if you know, all our emergency surgery from both sites is at St Helier, and we need better facilities for everybody at St Helier. And we're about to go out to tender for a new ITU, which will be bigger, with more beds in it than we currently have, which also is at St Helier.
Right, next question is, why are patients who are operated at Epsom having to go to St Helier for follow-up?
So I think that came from Bess, and I think it was a specific.
Was it?
Yeah, it was a specific thing about a particular orthopaedic surgeon who had a subspecialty interest and did his outpatient clinics at St Helier. But we have a fracture clinic. We have all the surgical outpatients on both sites. So if a patient,
that was the first available appointment that was there.
So if a patient wants to have their early patients,
So you
I
think
think
should be fine.
it was a generic question or a question about a specific patient to be able to answer the question.
But the general principle is that we do outpatients at both sites. There may be some specific reasons for clinical indications why it is better to have a centralised clinic up one site or the other.
Right, okay. It's just that all I can say is from my part of the world, as from February, we're going to have less buses to get anywhere, full stop. I mean, where I used to work, we've got problems now, how are we going to get our staff in? And as you know, we have 700 staff working there, and I know not all of them work there all of the time, but we are really pulling our hair out how we're dealing with it. My question is, well, it's not really, it's, you've been under an awful lot of pressure in the last sort of 6 weeks or so. And I know you've been out on social media about having awards. What about for all the rest of the staff? Because you've had pen pushers and backroom staff, pen pushers is a nice word, but you've had a lot of backroom staff doing all the extra things. And I really do feel that they should be rewarded or acknowledged in some way, because you always hear about the doctors and nurses, but what about the porters, the cleaners, the people on reception, all of these? I mean, your people on reception at A&E, the abuse that they get is pretty ghastly.
So two things, three actually, after that. We our winter heroes that you know about, and these are for the people who don't necessarily normally sit on frontline places and get acknowledgement. The second thing is I put out a plea for staff in the back office to come forward to help us with making beds. I can train anybody how to make a bed, helping to unwrap the food at meal times. And people say, yes, please, we just want to do our bit, and we've all been told over on that. We also have the service improvement team, and I'll hand over to Dan because they've been really helpful.
Yeah. So a lot about achieving the emergency department standard is about how you can keep patients moving on their journey through the hospital as quickly as possible, because that keeps the overall numbers in the emergency department low, and that makes it easier to deal with the current pressures. So a lot of the backroom people who've been bearing more stress counterintuitive have been those who perhaps manage our bed stock, or who manage patients across the boundary between us and social services. They've been under immense pressure. We're very clear about recognising that. We've talked about staff who've helped to feed patients, porters who've stayed to go on. And we've made a point of walking around ourselves, and Ruth now has a specific point during the week where she walks to the hospital to say thank you to people and also pick up feedback. But a lot of this is actually about how we just recognise and value our staff on a daily basis and actually saying thank you at a senior level. So I make a point of writing personal letters to people who I know have gone above and beyond, saying thank you to them. I think most of the rest of the exec team behave in a similar way. So I think there's something about we can't give everybody an award, but we can give them a Costa or a Christmas lunch voucher to everybody who's working to say thank you, not just the doctors and nurses. So it is about a whole team effort. The service improvement team, so we know that some of it's about how you integrate the efforts on wards of the nurses, the doctors, the therapists perhaps, the radiologists in terms of getting people for tests and the porters. And the service improvement team have been out and about since the beginning of December, working specifically on that integration of teams on each of the wards. And they've probably gone above and beyond more than anybody else of the non-clinical staff over the last few weeks. So it's absolutely about recognising the whole team effort, not just those who are working clinic.
Yes, Brian Yates. The radiology department, have you got any plans for increasing the equipment there, or speeding up the process? It seems to be lagging in many ways. Not in general, particularly on CT scans. I mean, does it need new machinery or stuff?
So radiology needs lots of new kit, in particular because radiology has gone from being analogue to digital. And so we are now in a 5-year programme to replace 29 pieces of radiology equipment, which started last year, and the first bit was the new CT scanner at St Helier. And on this site, there's at least 2 of the rooms that were going to be digitised this year, which means new kit. But the plan is at the end of the programme, we will have replaced the entire radiology fleet.
You'll be meeting the supply of
but the demand for radiology keeps on increasing. And so there's a company called InHealth who we buy we rent mobile imaging capacity from. And if you've been at St Helier, you will notice that even though we have a new CT scanner and we have a new MRI scanner, we've now got the lorry back again to keep up with demand. And on this site, I'm hoping we got a request for quite a considerable amount of money to turn the lorry, which is the capital lab, which is also a bit of radiology, into a permanent building, and that will increase capacity on this site too. So there's quite a lot of investment going in.
Yeah, so actually it's in the programme somewhere, it's a 5-year programme.
Yeah, and we started it, and there is new kit.
Okay.
Can I add, there's also something about the process. So even if you put as many machines as you want, we still often find ourselves, particularly with CT machines, having to mix. So if you're doing a CT-aided interventional radiology list as a consultant, what we're having to do is often fit our emergencies into those, and that's why the additional capacity damage is
Staff backup as well.
So it's not just the staff backup, it is about the ability, because you've got to interrupt the interventional radiology list. And once that's underway, it takes as long as it takes. So you can't predict for some of these things whether it's 10 minutes, and therefore plan to that. So we know there are disruptions to flows, and we're trying to do some improvement work. The other difficulty is actually about the reporting of all the radiology work. So we know there has been an issue nationally about 1 or 2 trusts in the south who had years worth of unreported radiology scans. So we've been both using an outsourcing company and our own radiologists to ensure we stay up to date on
Well, as long as you've got your mind on it, that's
it's
what
at
I
the
was
forefront of
asking,
my
yeah.
mind. Yeah.
And one further question. I noticed in the May CEQC report, there was a red blob on one of the items, which was due to nursing. One of the major comments was about the nursing in surgery. Now, has that improved? Is really what I'm asking.
So it was about leadership in surgery, as written
On the last
CQC.
report, Brian, was it?
Well, it was the last report by CQC in May.
May 16.
16. It's quite old now.
So yes, there was leadership.
Oh, it was 16.
Yeah.
Well, I'm sorry about
So
that.
they were inspected in November 2015, and then we got our report in May 2016. In between times, obviously, a lot has happened, certainly from the nursing perspective, and Ruth will talk about the doctors. We've brought in very experienced senior surgical nurses, and I hope we've seen an
Oh,
improvement.
so you're on track, really, is what you're saying.
I believe we are, but
Yeah, and
It did sound like it.
the other
Your
thing
report.
is that if you think back to those days, the surgery division was a very large division with just one clinical director covering all of surgery. And now we have 3, one for orthopaedics, one for general surgery and one for anaesthetics. So lots of changes which are positive.
Okay, well, thank you.
That's fine.
Okay. Next.
Sorry, yes, I wanted to ask about DNAs. Obviously, we have the phone calls now, but obviously not everybody will pick up the phone call because of the number that comes up on the screen. I just wanted to know how you found that impact of, have DNAs reduced because of that, and what is your next step in reducing it even further? Because obviously that's a huge thing on your budget.
So our DNA rate is really low.
Okay.
I'm not from memory, it's about 6%.
It is. So a lot of consultancy companies will sell you services to get your DNA rate down to 6%.
Right, yeah.
So if that puts Daniel's number in context, a lot of trusts are around the 9, 10, 11% mark. So we know we're ahead of the curve. That doesn't mean we don't have more to go. And all the things that you talked about, does everybody answer the phone? We're trying to come up with some other ways, whether we can do it by text or whether we can get people to text.
We do text, sorry.
Yeah.
So,
On a clinical level, we're also looking at we're doing a lot of work to try and make sure that all of the outpatient attendances are offering added value to individual patients. So a number of the outpatient attendances that we have might be an annual review, and we're exploring, are there other ways that we can offer outpatient surveillance? So part of that might be utilising increased technology with telemedicine or virtual review of blood test results, or liaising directly with GPs, or potentially offering advice directly to GPs to stop patients coming to a clinic where they don't need to come to a clinic. So there's a lot of work behind the scenes. And then for patients who don't attend, we ask our clinical staff to still review that patient to make sure either we offer another appointment or we offer advice to the GP about the ongoing care.
And that's quite important in terms of safety net safety.
Move to the middle row.
I'd like to ask a question, if I may. You talked earlier about how many people in outpatient appointments were cancelled, how many scheduled operations. You didn't mention the fact that you had to use the children's ward for emergency admissions. How, if you were to go to a single site for for emergency and acute care, how would that impact your ability to change the use of beds in these high demand periods?
So there are 2 big issues that we have experienced in managing all this winter pressure. So the first is about staffing, and we already run our staffing very leanly because we're trying to manage acute patients on 2 sites. And when you need to increase your staffing because you've got more patients, it is really hard to do given how stretched the staffing currently is. So if the staff who looked after acute patients were in one place rather than 2, we would find it much, much easier to flex up the staffing to enable us to look after more patients safely. So that's quite hard to comprehend, but it's absolutely true if you see how painful it is for us to ensure that all our routers are full in normal circumstances, let alone when you're trying to have more patients. In terms of the configuration of our buildings, they are a massive handicap. So one of the reasons why we end up using the day wards at both sites is because our children's designed wards from about 20 or 30 years ago, when you were admitting lots and lots of children. And the length of stay for children has come down dramatically. And we don't actually need all the children's capacity that we've got. So it is rarely full. So you end up with empty space. And that would be, if you were designing in the new facility, you'd actually design fewer children's beds and more adult beds, because the demand for adult beds is going up because the population is getting older. So I think there are only 3 trusts in the country that currently use children's wards for adults, but if you look at them, they're the hospitals that are really, really old in their designs. And when you look at A&E, If you compare the layout of Epsom to the layout of St Helier, they are completely different. So Epsom A&E, which is a relatively new build, is built as a racetrack design and has lots of capacity for looking after sick people and managing the patients safely in the department. If you compare it to St Helier, and I showed Siobhan graphics on Monday, it is more like a zigzag. And you're completely constrained as to where you can manage an increase in patients safely, and it puts a real pressure on the system. So one of the reasons why we have ambulance handover delays at St Helier more than Epsom is because there is no dedicated space where ambulances can hand over their patients and we can nurse them in an environment which isn't on their trolley that would come in on the ambulance. So we can't cope with surges of activity nearly so well at St Helier as you can at Epsom. And then the last thing I would say is that if we were able to build a new specialist acute facility, wherever that was, that's like 500 new beds into our system. And I would be fully intending to leave capacity at the existing Epsom and St Helier buildings, which, because we're saying we will refurbish the wards in the existing buildings so that the bed spacing is better and there's more ensuite facilities. We will still end up with spare capacity as a result of that. So our ability to cope with surges will actually go up because we will have a whole heap of brand new extra capacity, more than we currently do.
There's a few things I'd like to say in reply to that, actually, Daniel. At the moment, as I understand it, you're using non-acute facilities like the children's day treatments for acute admissions. And that's a flexibility presumably you wouldn't have if you only had an acute centre.
Yeah, but what I just said to you is that we changed the balance of children and adult beds because we don't need as many children's beds as we have got, and we need more adult beds.
But you are actually cancelling appointments for children. In the last couple of weeks, you were cancelling planned appointments for children because you were using beds that you would have used for children.
So that is partially correct. Yes, we have cancelled some children's surgery, but you would have redesigned the other parts of the children's service to enable you to do this. We are...
What I'm saying is by having 2 sites and more beds, it must give you more flexibility for critical high demand times.
If I can sort of help support, we absolutely do that already. We move patients where it's appropriate depending on their site, so we move them from one site to another. But both of our sites at the moment are under extreme pressure, and a lot of the time we find that one is under slightly more, and therefore we can potentially move ambulances from one
But you
site
won't
to
be
the
able
other.
to do that if you've only got one, is my point.
If in our proposals I would say to you, we think you could manage with less beds in total, I would agree with you. But we're not saying that. We're saying we think we need the same number of beds going forward as we have today, more or less.
Well, most of your scenarios are actually less beds.
But the bitness is all about being more efficient because we can use our
No, but we're talking at
staff.
the moment about beds.
Yes.
And that's what I'm asking you about. And I mean, you actually said a minute ago that the demand for beds are going up. You have said repeatedly that the demand for beds in modern medicine, the demand is going down and we don't need so many beds as we used to need. Now, which is the case?
But both statements are true depending on the context in which you're asking the question. So I think we've answered your question as best as we can.
Well, you've also said that we're putting in 500 new beds. That's not the case, is it? You are at best hoping to keep a similar number of beds. You just said we're putting in 500 new beds. That's not true. That's not the case, is it?
So what is the case is we're asking for £400 million to build a new specialist acute facility that would have 500 beds in it.
Yes.
Yes, I'd say that was a new building that had new beds in it.
But you are losing the beds in the beds that you currently have.
So what I then try to say is, so then we want to convert the existing bed capacity into something that is more functionally suitable for patients to to convalesce and rehabilitate in.
Exactly, and so your 200 beds that you said to me that you would hope to keep in St Helier and Epsom, you told me they would be mainly for rehab of old people.
Yes.
So they wouldn't be suitable beds for your critical and emergency admissions, would they?
But if you look at the last time we did a bed audit, which was only in November,
Right?
at St Helier, there were 100 patients in beds who were not acutely unwell. And so that cohort completely fits into the model we have created. And on top of that, there's a whole bunch of patients who also do not need to be in an acute hospital setting. And what I was trying to answer your question by saying is, we will have more capacity if we have a new building to be able to cope with bed pressures in surges of activity.
How would you if you've got fewer beds?
Because-
How will that give you more beds? 500 beds is less acute beds than you've got now. How by only having 500, wherever they are, whether they're brand new or old, wherever they are, that's less beds.
So I think we now into the conversation we normally have. So
But you're not answering, Daniel.
well,
As usual.
so I think we've tried to answer. So should we try something else? Mr. Ashton, we'll come back here.
Right, I've got two questions. First one is about my belief that when you reduce the number of sites at which there is a fully functional blue light A&E and a consultant-led maternity department, people will die. I have made that assertion and you have objected to me making that assertion. There is now evidence from 68 senior A&E consultants that patients are dying on trolleys. We know from the history of Newark that the reduction in the number of A&Es resulted in additional deaths that would have been avoided otherwise. We know from the Northumbria Specialist Emergency Care Hospital that you said was your model. There have been years, succeeding years, where people have been waiting on trolleys without either paramedic or admission to the hospital or any care. And we now know that there are premature deaths occurring on trolleys because of lack of capacity in A&E, due to the reduction in the number of places, as you reduced in North West London and led to catastrophe at Northwick Park. So what have you got to say now about my assertion that people will die as a result of these reductions that you are planning?
So I'm not sure that's really a question. But
I've just asked you, what have you got to say about people dying because of changes like the ones you propose?
So I think you're making a set of national statements about a national position, and you will notice that no one from Epsom and St Helier signed that letter, that people have not been waiting in corridors in Epsom and St Helier A&E departments, and if we had big concerns about patient safety, having just had the CQC in here for 3 days watching the entire way we manage emergency pressures under stress, if there had been issues of concern, they would have flagged it.
I'm not talking about now, I'm talking about your plan. Then there will be only one site, if at all.
So if you were right in your assertions, we would not have the entire backing of the clinical community in Epsom and St Helier. The clinicians would be saying, this isn't right, and they're not. They're all saying, almost 100% of the clinicians are saying, this is the right thing to do, and we want to treat our patients in a fit-for-purpose building for the 21st century in teams that enable us to work safely and effectively. So every time you ask the same question, every time you
You're going to give the same answer.
Yes.
But there is no evidence to adduce to support what you say those people believe. No evidence at all. There's a massive evidence in support of what I am asserting.
So I think
and you are simply ignoring the fact. And you're claiming that because you can cope with 2 centres, you can cope with 1. That's not actually sustainable as an argument.
So you have no evidence either.
I do. 68 senior A&E consultants have reported premature deaths on trolleys because of A&E reductions.
No, that's not what
It's not what the list says.
No.
But I think we've had this dialogue through the public engagement over the summer, so I think it's a repetition of the dialogue that we've
No,
had
it's
many
not,
times
because all you
before.
said was about necrophilia, which has nothing to do with the question. We've got video recordings of that. And that brings me to my second question. I want it on record. I want you to say why, at this public meeting in a public building, you said I would be ejected if I insisted on exercising my legal right to film this meeting. You claimed that there were members of the public who objected because they appeared on our films. I don't believe that to be the case. I don't think you can identify people who are on film that we have put out. Now, what's your reason for refusing?
Because we are filming the meeting. There is a camera over there. It will go
And you
on.
have control of what the public see, and it goes to a very small audience.
I know.
We have millions of people seeing our films, and you want the public to see what you are saying.
No, it will be published in full. Everything that you have said, every question that's asked, it is published in full. Unlike some of the recordings that we've had, which are snippets of meetings, this is a full explanation of the whole of the meeting. So I dispute the fact that we're putting snippets out, because that's absolutely not true.
I didn't say you were, I said you have the opportunity to.
Well, we would not take up that opportunity.
Time for 2 more questions?
Sorry. May I ask a question slightly tangential to this? It's to do with the car parking. Now, you've probably seen the article in The Guardian this week, I'm sure you have. And I've got 2 questions about this.
Yeah.
Firstly, do the proceeds of car parking actually go to the NHS, or have you franchised it?
Yes.
So everything that is paid in goes to the NHS?
So we pay, so MPark are a parking contractor.
Yeah.
We pay them a fee for managing the car parks.
Sure, but the balance then comes to the NHS.
But
So that's not necessarily a problem if you want to support the NHS.
No.
That's the first point. The second point related to this lady's unfortunate experience in the evening, where she, I think, had 3 1/4 hours or whatever, and ended up with having to pay £8 in the early hours. Now, is there any possibility that you could look at flexing that, so that if folk come at, say, I don't know, midnight till 8 in the morning, there's no charge?
No.
You can't?
No. So for our staff who are working night shifts, parking is free.
Right.
Because we don't want to put them in unsafe scenarios where they have to walk back to their car park quite a long way away.
Sure.
We have a lot of concessions for patient parking. So if you are a regular visitor to the hospital, we cap the parking charges at £10 a week. And if you are delayed in outpatients or pharmacy by more than an hour, we also refund most of your parking fee.
Right.
And we have set our parking rates to be broadly in line with neighbouring hospitals, and trying to emulate what the rates are in a public car parks around us.
I think what you've said is quite clear, that there's no capacity to restrict over certain hours. The machines have to work, and that's the end of it.
Yeah.
And I also believe that the St Helier charges are the same as here, aren't they?
Yes.
So from that point of view, we should actually all appreciate we're putting something, albeit a small piece, into NHS coffers.
Yes.
Yeah, no, thank you, that's fine.
Yeah. Thank you. And last question, back to you.
The flu epidemic, I read yesterday that Sutton and Banstead were on the red alert.
Yeah.
They've now expanded it, I'm sure you read the article like I did, now to cover an awful lot of Epsom, Leatherhead and all round here. How are you going to deal with it? And the other part is, what is the percentage of people that have been coming into A&E that have actually needed A&E? Because most of them, I've been telling them to ring this number, the doctor's one.
111.
Yes, and no, also the one that Surrey Down CCG had, because that has been extended, but it wasn't publicised a lot.
So they're very busy, that service.
Well, yes, I agree, but...
So we've got a fantastic relationship with the GPs in the Epsom area.
Yeah.
So they provide GPs into our A&E, and we can stream patients from our A&E into their capacity, because they've got a number of hubs, and we do that, and it works. It's really hard to answer the number of people who should come to A&E who have an A&E condition.
So we think the public, so based on the evidence of the last 48 hours, we've seen the numbers of total attendance, particularly in St Helier, drop very slightly. And the feedback from shop floor is that they think that it's some of the people who perhaps come in with the less serious end of complaints, making a conscious decision that they know the system is under pressure and seeking alternatives elsewhere. and there's no evidence of any drop-off of people at the higher end of acuity avoiding ED. People are still coming. In terms of the numbers of flu attenders,
Charlotte has. Yesterday's data, here we go, from Public Health England.
Because we see it's just coming from Public Health England, and I shouldn't really check mine, but I am interested in it. So let me tell you, I'll give you the highlights basically. Community influenza. Overall, there have been 233 new acute respiratory outbreaks, but actually 209 of those are in care homes.
And is this national or sorry?
National. So I would say care homes are a hot spot, and of course then they may well bring their patients to us. The other thing I've literally just skim read and picked up is there is broadly double the amount of admissions this week into hospital than last week. We already know that about a third of our cases on intensive care are confirmed flu, and we've also got some paediatric cases as well. So I know from the bed state that we've got some children in with it too.
I think whilst flu is a really unpleasant illness, the vast majority of people who have flu can be managed in the community, and usually the consultations through the GP is the appropriate route, but obviously if people become acutely very unwell, then the hospital is the place for their care, in the same way that if they presented with any other serious illness.
So you can go onto this website called flusurvey.org.uk,
Yes.
which is the Public Health England one. Right? So the redder your area, the more flu there is, and you can see that, sorry, southwest London, I lost it. There, we are in this blob here, we're in quite a flu hotspot. But if you follow this map, you'll see that the country is going redder and redder. So this is going to take the whole of the month of January, I think, before it burns itself out, which is why they saw, nationally they saw this coming. That's why they asked the whole NHS to postpone non-urgent operations, because people could see that there's going to be a huge number of admissions with people with flu.
So far with our staff, we did really well with our vaccination of our staff. Our staff were great. They really picked it up and ran with it. And actually last week we had a whole more, another bunch of staff come through saying, you know what, I want it. Free vaccination.
Was there any truth in the fact that the flu didn't cover what is arriving on the horizon?
Oh, the Austin. This is one for you.
So the prevalent strain of flu is something called the subtype, is H3N2. The vaccine does cover that, but perhaps not 100%. You may remember the episode of H1N1 flu, which was a very serious outbreak of flu a few years ago. The vaccine seems to be covering that quite well. We are 6 months behind Australia, because Australia had their flu epidemic in their winter and summer, and the evidence from Australia and the evidence from the vaccinations suggests that there is still definitely benefit in having the vaccine, both to you as an individual and to the population as at whole.
But if you go onto the iPlayer and listen to the Today programme this morning, there was an incredible professor of microbiology from Cambridge who was really lucid all about how the flu virus works and why the flu jab is a really good thing to have done. What I can't remember is when it was. I listened to it.
I thought it was yesterday evening.
Well, it was the
7
following
o'clock
morning.
about 7 o'clock this morning.
Between 7 and 7:30.
Yeah,
So go back and look at the BBC iPlayer. He was really phenomenally gifted at explaining.
What was the subject? What was
This
the
back
saying?
about flu vaccine.
So-
About
so on
should
the-
you have the flu
Flu
vaccine?
vaccine.
Yeah, on the Today programme, if you just listen between 7 a.m. and 7:30 on the iPlayer, he was on. It was really very good. Well, I think we've come to a natural end. Thank you very much.
Thank you very much.
Yeah,